Good afternoon, everyone, and welcome to the fifth installment of ADB's webinar series, Asian Impact, showcasing research in action. I'm Rana Hassan, a director in ADB's research department, and I'll be moderating today's discussion on approaches to reopen our economies while keeping the spread of COVID-19 in check. On January 23rd of this year, Wuhan in Hubei province became the first city to implement a lockdown featuring strict restrictions on the movement of people, including for work, as a tool for suppressing the spread of COVID-19. Since then, lockdowns of varying stringency and duration have been implemented globally. Starting late April, we've seen some countries or locations gradually lifting or easing lockdown measures, but today we're also seeing some signs of relocking as COVID-19 cases reemerge in various locations. While these lockdowns have helped restrict COVID-19 transmission, they have taken a big toll on economic activity and people's livelihoods. A key question for policymakers everywhere is, how can we reopen our economies while keeping this disease in check? We have today with us 5 individuals who have been spending a lot of time grappling with this question from different perspectives and vantage points. And I'm pleased to introduce you to them. First, let me introduce Dr. Kesha Prem. Dr. Prem is an infectious disease modeler at the London School of Hygiene and Tropical Medicine. She's received her PhD in public health from the Saw C. Hawke School of Public Health at the National University of Singapore, where she maintains an honorary position as a research fellow. She collaborates closely with the World Health Organization to build computation models for infectious diseases and conduct cost-effectiveness and feasibility studies. Among others, Kesha has led a seminal study that has developed social contact matrices, which are a key tool in the modeling of infectious diseases for over 150 countries. Welcome today, Kesha. Second, I'd like to introduce Professor Soonman Kwon. Professor Kwon is at the Seoul National University's School of Public Health, where he also used to be the dean. He's a health economist with over 30 years of experience working on a vast range of issues, including universal health coverage, health finance, health systems, and policy. He's held visiting positions at the Harvard School of Public Health, at the London School of Economics, and University of Tokyo, among many others. He was the chief of the health sector group at the Asian Development Bank a few years back, and he's the founding director of the WHO's Collaborating Center for Health System and Financing. He's published extensively in the field of health, and he's currently the president of the Korean Health Economic Association and president-elect of the Korean Society of Health Policy and Management. He holds a PhD from the Wharton School, University of Pennsylvania, and he's taught at the University of Southern California School of Public Policy until 1996. Welcome, Professor Kwon. I now move on to Dr. Rouselle Lavado. Rose is a senior health specialist in the social sector division in Central and West Asia Department of ADB. She's led numerous health projects across Asia, both at the ADB as well as the World Bank, where she worked previously. She's been a senior fellow at the Institute for Health Metrics and Evaluation, an independent global health research center that's based at the University of Washington in Seattle, and she's also been at the Philippine Institute for Development Studies. Her research has been published in the WHO Bulletin, Lancet, the Journal of American Medical Association, among others. She's obtained her PhD from Hitotsubashi University, and she's taken her postdoctoral studies at the University of Washington. Thank you, Rose. And let me now turn over to Liming Chen. Liming is a young professional at ADB's research department. He has obtained his PhD in economics from the University of California, Santa Barbara, and his bachelor's degree is in economics also from the Fudan University in the People's Republic of China. Being a young professional, Liming has had to dive straight into a lot of COVID research, and in fact, we're going to start with a presentation by him. But before we get to that, let me just make a quick note for our viewers. You may send us your questions through the Q&A panel that you can see on the right side of your screen at any time. You may also like questions asked by other viewers, and we'll try to answer as many questions as possible during the panel discussion. So as time permits, we'll try to get to these questions. So Let me go ahead and now invite my colleague Liming Chen. And what Liming is going to be doing is he's really going to set the stage for today's panel discussion. He's going to make a short presentation that utilizes cross-country data on COVID-19 control measures, case data, economic activity, and mobility, and tell us about some of the patterns we see in this data. So with that, thank you, Liming, and over to you.
Thank you, Rana, for setting the stage. It is my pleasure to share the findings of our collaborative work. We draw from global evidence to examine how to restart the economy while still keep the COVID-19 in check. Next slide, please. Since the outbreak of COVID-19, all economies have adopted different kinds of policies for containment and suppression. There are lockdowns to restrict people's movements and also pharmaceutical measures to ramp up testing, tracing, and mask mandates. Now, I bet every single one of us have been affected by one or more of these policies. And the question everyone has been wondering is how effective they are in controlling the spread and how are they associated with economic downturns. For this talk, we take a crack at both questions by analyzing data from 75 economies on control measures, behavior shifts, and the COVID-19 spread. Next slide, please. First, we present some global patterns on mobility, policy, and COVID-19 cases. There's a considerable large variation among experience of each economy. There are places that introduced sharp lockdowns very early and saw a huge decline in mobility, such as India and the Philippines. On the other hand, Republic of Korea has less stringent lockdown and suffered less mobility reduction thanks to rigorous tracing and testing. Thailand is one of the few developing economies that has seen surprisingly lower number of cases. So the policy and mobility responses are quite diverse. Next slide, please. These figures show over time the number of economies adopting each policy. It is apparent that the lockdowns were widely implemented around early March and have been gradually relaxed in more and more places. For example, now people are allowed to go back to their offices, and the schools in some places have been reopened. On the other hand, pharmaceutical measures have been gradually gaining coverage. More places are now enforcing mask wearing and ramping up testing and tracing. Next slide, please. So announcing policy is one thing, effectively implementation is another beast. This figure shows that during the peak lockdown phase, people stayed home less in developing economies given the same amount of lockdown stringency. This indicates that lockdown might not be as effective in controlling people's movement in the emerging economies. One potential reason for this is that people in these places simply cannot stay at home. For example, a recent study from the University of Chicago shows that emerging economies have a lower share of labor force that can work from home. Next slide, please. So going back to the question in the beginning, which policy has proven to be the most effective? We provide evidence drawing from the international data in the first 6 months of this year. For outcome variable, we use effective reproductive rate, also known as RT, to measure the spread. The main advantage of using RT is that it accounts for population size and reporting delays, so it's more comparable across locations. We also look at Q1 GDP growth as an outcome. For explanatory variables, we collect data on policies from the Oxford Government Response Tracker and complemented it with data on mask use and paid sick leave from different sources. We use Google Mobility Report to measure behavior response, and our main empirical method is panel regression with time trend and fixed effects. Next slide, please. This slide shows our main results, including the coefficients and 90% CIs. There are several findings we would like to highlight. First of all, we find that intuitively, places where people stay at home more is associated with higher RT reduction. But if the household size is larger, this association is weaker. This implies that asking people to stay at home may be less effective if there are more people in the same household. Secondly, among all lockdown measures, we find that school closure, gathering bans, and mass testing is associated with RT reductions, while the correlation on public transport closure is not that significant. Places enforcing mask mandates also show a reduction in RT. Last but definitely not the least, the biggest coefficient we found is not with any individual measures, but a policy combination of contact tracing when carried out with paid sick leave. Intuitively, if you offer people paid sick leave, it incentivizes them to be more truthful in reporting their symptoms. Otherwise, people may have to choose to hide their cases to avoid income losses. Therefore, paid sick leave can make tracing easier and more accurate. Next slide, please. So the flip side of the story is that these measures, while effective, might also take a toll on the economy. We found that early adopters of mass testing, tracing, and gathering bans experienced a smaller decline in growth. In contrast, early adoptions of schools and workplace closures show considerably larger decline in Q1 growth. Next slide, please. To summarize our key takeaways, the contact tracing combined with paid sick leave is highly effective in controlling the spread of COVID-19. Mass testing, gathering bans, and mask mandates are effective and also less costly for the economy. So this has some clear policy implications. When future waves hit, and we know they will, control measures proven to be effective and with less economic cost should be implemented early and fast. In addition, such measures should be the central feature of the new normal until we reach herd immunity. That's it for my talk. Thank you very much for your time. I look forward to the discussion from panelists. Back to you, Rana.
Thank you very much, Liming. Let me now turn to our panelists. And I'm going to first call upon Keisha. Keisha is going to present some of the work she's been doing using age-structured epidemiological models. And I think one thing that's very clear from this crisis everyone will appreciate is that COVID-19 really affects different age groups quite differently. And so there are models which take into account this age structure, there are models which don't, and Keisha is going to be showing us some of her findings from research conducted using these age-structured models. So with that, Keisha, over to you.
Thank you. So good day, everyone. Thank you for joining us for this webinar, where we try to make sense of, how do we let loose without letting up as we restart economies while keeping COVID-19 under control. So earlier, Liming provided some modeling insights with the current COVID pandemic. Now I will cover three aspects of this issue. Firstly, I will share briefly about what mathematical models can tell us. And second, what we have learned from the earlier waves of the pandemic. And I'll wrap up the discussion by pointing out some implications of reopening up a country or a region. Next, please. So many transmission dynamic models that simulate how COVID-19 spreads are similar. They are formulated around how individuals in the population move between states, how quickly susceptible individuals might acquire the infection, become infected, and then either recover or die. The most basic of such models assume that everyone has the same chance of acquiring the infection from an infected person. They assume that the population evenly interacts with one another and that individuals with the disease are equally infectious until they die or recover. But more advanced models account for age, sex, health status, and social behaviors like mixing patterns of individuals who meets with whom, when, and in which places. Age disparities observed in cases could be explained by children either having lower susceptibility to infection, a lower propensity of showing clinical symptoms, or actually both. So one of the challenges we face in the middle of the outbreak is that we don't typically observe the transmission events themselves. Instead, we just observe people becoming ill and needing hospitalization later. The cases and the deaths that we see today probably started as infections weeks ago. So next, please. When researchers managed to reconstruct the full transmission dynamics of COVID-19 in Wuhan, they found two key features. Firstly, the virus was highly transmissible in the absence of any interventions. And secondly, the covertness of COVID-19 infections make it hard to detect cases because the majority of infected individuals are asymptomatic and mildly symptomatic. They found that up to 87% of the cases in the Wuhan epicenter prior and in the earlier periods of the 2020 was actually undetected. Next, please. Another analysis on the first 300 cases reported outside of China found that about 60% of the imported cases were undetected in the early phases. The majority of these undetected imported cases generated extensive chains of local transmission in other countries outside of China. And this probably led to the silent spreading of epidemics in the seeded countries. So in combination, these two features make controlling COVID-19 much more challenging compared to the other coronaviruses such as SARS and MERS. In the absence of the effective pharmaceutical solutions, as the country opens up their borders, the test, trace, and isolate strategy should not forget importations. Moreover, because of the stealthy nature of the virus, there could be a substantial number of undetected cases which may pose a risk of resurgence if reopening too early, with all control measures prematurely being lifted. It is also worth remembering that countries implement contact tracing alongside social distancing and not a total substitute for it. Next, please. Much of epidemiology exists on a spectrum, so things are not safe, they are safer. One of the challenges is clear communication and turning these nuances into key messages. For instance, we should not really be asking, is it safe to reopen a country or a region? Instead, we should really be asking, what needs to happen to make reopening a country or a region safer? We have to always stay vigilant because the progress of containing COVID-19 is fragile anywhere as long as the virus is not contained everywhere. As we have witnessed, there are several success stories in several places that have come undone. In most places where COVID-19 transmission is on a big decline, there is still likely that there are a lot of susceptibility. So this transmission is memoryless. The virus does not care how good your measures were in the past. All that matters for future epidemics is how good they are right now and what control measures you have in place to prevent the future spread of the virus. So I really appreciated what Li Ming shared earlier when he discussed the different kind of measures that can come in place together. So countries need to also find a sustainable combination of this kind of control measures for at least a year or even longer if they want to avoid large outbreaks. So is it more economically disruptive to have ongoing social distancing and working from home arrangements, or regular reactive lockdowns, or even a large-scale border closure? So we also need to come to terms with the possibility that a good vaccine may not be available in the next 1 to 2 years, or in fact, even longer. So basically, as I come to an end, controlling COVID means reducing interactions between infectious and susceptible individuals. And this can be attained from a variety of control measures that comes with different degrees of short-term and long-term disruptions, as well as effectiveness. Thank you.
Thank you very much, Keisha. Fascinating presentation. We're now going to introduce our final panelist, and this is Mr. Vince Dizon. He's the Deputy Chief Implementer, National Action Plan Against COVID-19. He's concurrently the Presidential Advisor on Flagship Programs and Projects and the President and Chief Executive Officer of the Basis Conversion Development Authority of the Philippines. Vince is in fact playing a very key role in coordinating and bringing together the collective efforts of the national government here in the Philippines, local government units, and private sector partners in increasing the testing capacities here in laboratories in the Philippines. He's a leading figure in the flagship T3 program. He's held many positions prior to this, including being Undersecretary for Political Affairs of the Office of the President of the Republic of Philippines. He started his career as an Assistant Professor of Economics at De La Salle, and he was a Chevening Scholarship Awardee in 1998 and obtained a Master of Science in Applied Development Studies from the University of Reading in the United Kingdom. Vince, it's a pleasure to have you here, and we'd love to hear from you now in really what is operations at the field level. So over to you.
Thank you, Rana. First of all, thank you to ADB, not just for this forum, but also for all the help you've given to the Philippine government, especially in leading the formation of the Test, Trace, and Treat T3 Coalition. Again, thank you so much, and for all the help you've given as well to the infrastructure program in the Philippines. If you'd allow me, okay, there you go. Okay, so the T3 Coalition, spearheaded by the ADB and practically all the large conglomerates in the Philippines, was formed in late April of this year, together with the national government, as a way for the private sector to assist the government in its efforts responding to the call of our president for a whole of nation approach to fighting COVID-19. Next slide, please. So the T3 model for dealing with COVID-19, similar to what has been presented earlier, is based on the prevent, detect, test, isolate, treat, and reintegrate model. Next slide, please. So, but now, as you're probably aware, several pronouncements from our government have led us to already begin the process of loosening up and opening up, because obviously prolonged lockdowns have the effect, have the negative, very negative effect of really devastating the economy. And now we're in a situation where we have to balance both saving the economy and also saving lives from COVID-19. And as a general principle, as we open up and as we manage COVID-19 in a more open economy, the responsibility for this shifts from the national government to the local governments, to private companies, and most importantly, to individual citizens. And tactics such as localized lockdowns, massive information and very strict enforcement of minimum health standards, as well as discipline for individual citizens comes to play. Next slide, please. And of course, minimum health standards of washing your hands, wearing your masks, keeping your distance become important. But next slide, please. As well as the protection of the vulnerable. And we all know, based on our experiences in the past couple of months, that the elderly, those with comorbidities, pregnant, are all vulnerable to this and therefore must be protected from the disease. Next slide, please. So just to give you a short idea of where we are in the field. So in the early days, it was very challenging for the Philippines to test. And this was primarily because we did not have the laboratory infrastructure to test for COVID-19. And neither did we have the laboratory infrastructure all over the country. So next slide, please. So in February, we needed to, but we all knew we needed to aggressively test, especially in lockdown areas and barangays. Next slide, please. So in February, we only had one laboratory for 110 million people. Now we've been able to ramp that up, and as of July 27, we're up to 94 laboratories. Next slide, please. As a consequence, we have been able to drastically ramp up tests from just about 17,000 cumulative tests in March to now close to 1.4 million tests. And our goal is to test roughly about 10 million Filipinos by 2021, which is roughly about 10% of the population. Next slide, please. And as a result as well, our tests per day from just about a little over 500 in March is now at about 30,000 as of July 25, and which surpassed our goal of testing 30,000 per day within July. Next slide, please. Because of that, we're now very close to South Korea in Asia as having the most tests conducted. Next slide, please. And also in terms of tests per day, we're also one of the highest in the region. Next slide, please. Okay, so how are we doing it? We did it with a massive expanded community testing campaign where we used several of our big venues. This is one of our biggest arenas in Metro Manila. It's called the MOA Arena, the Mall of Asia Arena, which the facility tests roughly 2,500 people per day. It swabs 2,500 people per day, and on a daily basis, 7 days a week. Next slide, please. And most of the people lining up there are from the communities throughout Metro Manila. Next slide, please. For tracing, next slide, please. Right now, this is something that we were very weak on in the beginning, but we are trying to ramp this up. The head of our contract tracing program in the country is a mayor in Baguio City. It's a city in the north, which was one of the best, which boasted one of the best contact tracing and therefore the best numbers in controlling COVID-19. And his formula is a 1:37 positive case to 32 level 3 contacts that need immediate testing and contact tracing. Next slide, please. For isolation, we ramped up significantly our isolation facilities beginning April, May, and June. Next slide, please. And because of that, we were able to increase our facilities. The Ligtas COVID beds, these are the local government facilities, from just roughly 2,000 in April to about 70,000 as of July 10. Our mega quarantine facilities from 0 in April, we're now up to above 3,000 in July, and we're ramping that up even more today because occupancies have actually gone up already to roughly about 60–70%. Next slide, please. So these are just examples of quarantine facilities that were built. These are quarantine facilities that have individual rooms and bathrooms for people awaiting for the results. Next slide, please. And the next photos are actual quarantine facilities for COVID positive patients. This is in the World Trade Center in Manila. Next slide, please. And now we move to treatment. So this is the last part of the presentation. Please bear with me. Basically now, as we open up some more, we're aggressively building up our ICU bed capacity and converting a lot of our quarantine facilities into critical care facilities, which we are doing right now. And also, we are intensifying our stockpiling of the effective treatment interventions. Next slide, please. These include, we've also set up a one hospital structure command where the Department of Health coordinates with all hospitals in the National Capital Region in Metro Manila and does a very, tries to do a very efficient job at triaging patients, both mild, asymptomatic, moderate, severe, and critical. Next slide, please. Yeah, so this is just part of the one hospital command center. And I just want to finally present to you our interventions for treatments that have been having great success all over the world. So we are right now in the process of stockpiling a lot of these. High flow nasal cannulas, remdesivir, dexamethasone, Avigan, as well as trying to get as much convalescent plasma from those that have recovered from COVID-19. So with that, again, thank you very much, ADB, for your time and for your efforts at assisting everybody in throughout the region against COVID-19. Thank you very much.
Vince, thank you very much for that. A real panoramic view of the full range of pharmaceutical interventions that are really available to us today until a vaccine comes, which Keisha had mentioned could take some time. I'm sure there are going to be many questions for Vince in how different aspects of this operation is taking place. But for now, let's move to our next panelist, and that's going to be Soonman. We are going to be hearing from Soonman some of the steps that have been taken in Korea to deal with this crisis. This is a country which has had actually experience with different types of coronaviruses over the last several years, I think, starting from 2003. So with that, Soonman, over to you.
Thank you. Thank you for inviting me. I'd like to share with you some of my reflections on the Korean experience so far for the response for COVID-19. I think one of the key factors is the rapid and early response. That is the timing is the key. It is essential to flatten the epidemiological curve and to prevent overloading the entire healthcare system. I think that's the most important thing. Still, it is too early to compare the performance of different healthcare systems at different countries about the response for the COVID-19, because I think one of the most key concerns is what is the adequate performance measures in terms of the response of policy for COVID-19. For example, I think I'm very impressed by this presentation by ADB that you used the term reproduction rate, or RT or R naught. That's very good, and also GDP. But still, you know, GDP measures is a bit too early to measure the true impact on GDP. And also RT, there are many issues to have a correct estimate of RT. So, and also whether we measure the performance in terms of short-term versus long-term, and how to measure the impact of COVID-19 on other parts of the healthcare system. For example, potential excess mortality of patients with non-COVID-19 things. So maybe we need to use like a disease burdens or deaths. But anyway, so there are a lot of issues in the measurement of the performance, but I'm very impressed by the team, ADB team, on that you did this very good job. And I already mentioned to Rana that I'm going to use some slides of your team in my presentation to the Korean government next week. In the Korean experience, I think you, as you already mentioned, the two pillars. One pillar is the test, trace, isolate, and treatment. It's the 3T plus isolation plus social distancing. In terms of the different measures of social distancing, I think the wearing a mask, I think this is the most cost-effective measure in the case of Korea. I don't know the case of other countries, but wearing a mask is quite effective. And people's compliance with wearing a mask is very high. Actually, we Koreans, we cannot understand why people in the US and Europe, why they are so reluctant to wear this face mask. Even me, I live abroad so long, but I cannot understand. Because I think it's a culture in East Asia. It's not just Korea, but like China, Korea, Japan. We often wear a face mask in the winter time during influenza. Even from our childhood, we are accustomed to wearing a mask in the winter to prevent the cold or influenza. And also in Korea during the springtime, like March, April, we have very severe sandstorms from China, Mongolia, and the air pollution is a very serious issue. So whenever there is a alert level, higher alert level for air pollution, the government recommends the people to wear a face mask. So we are so used to wear a face mask. So I think this is almost 100% compliance in terms of wearing a face mask. I think this is very effective tool in the case of Korea. Another thing in terms of other measures of social distancing, I think there's a very high level of participation. I would say it's a very active voluntary participation. Because people will voluntarily cancel meetings. There is little enforcement, but people voluntarily cancel meetings, avoid gathering together, things like that. So my question is why? Why is the major factor behind this very high level of voluntary participation? Well, in one sense, I can say, well, in a textbook story like social capital, trust each other, of course it is there. But I think another very important factor is that people are very scared. People are very scared of this COVID-19, especially at the beginning. So the compliance level was very high in March until, say, early April. But after that, the people's participation is declining over time. So we think that people's mobility, I think also, I checked this mobility data from Oxford, and it's almost get back to normal. So people's mobility is almost get back to the original before COVID-19 crisis. So, and it's a bit, I can understand that people are tired of it. So of course we can say social distancing works, but still people are getting tired. So we need more more clever strategy or maybe behavioral economics perspective, how to encourage people to increase compliance, increase participation in social distance bag. And I also found that it's a very important point that in the presentation of ADB, the importance of sick leave or paid leave. Because I raised the same argument in Korea, such that, okay, government actively advertise, encourage people to stay home. If you feel sick, if you have this cough and symptoms, don't go to work, stay home. But you know, everybody wants to stay home. Everybody wants to work from home, but they should work, somebody. So there should be a kind of policy measure, and paid leave is a very important element. And so in Korea, we started a big high-level discussions on the extending the sick leave system in the society. So I think it's a very positive aspect of positive impact of COVID-19 to give us an opportunity to more actively discuss about the introducing the sick leave system in the whole society. We had some cash compensation for those in the quarantine, but as you know, we are talking about sick leave system. This is very important. And finally, we initially started a kind of a uniform across the board social distancing restrictive measures, but later we introduced a risk assessment such that we assess the risk of different facilities. And then depending on the risk, we apply a different social distancing level, or even different provinces can introduce different social distancing. So very recently, about 2 weeks ago, there's a big spike of confirmed cases in the southwest province, part of Korea. It's one province. And in that province, the governor raised the alert level 1 level up compared to other part of Korea. So I think this type of risk-based differential policy measures is more effective than the uniform across the board policy measures nationwide. Thank you. Over.
Thank you very much, Soonman. So once again, these are some of the reflections from the field, from a country where you've really had a lot of experience in social distancing, and certainly this element of masks, as you pointed out, a very cost-effective tool, and probably something that's going to be with us for some time. Let me now introduce Rose Lavado. Rose, may I call upon you now to provide us your panel remarks? Thank you.
Thank you very much, Rana. So I will be focusing on 3 key takeaways on opening up the economy based on Li Ming's presentation, with an emphasis on lower and middle income countries. So allow me to focus on his first key takeaway, which is contact tracing combined with paid sick leave is highly effective in controlling the spread of COVID-19. So while we are doing this cross-country regression, we also did a modeling and a cost-benefit analysis of various non-pharmaceutical interventions in a country, in this case, the Philippines. I will be sharing with you, this is a preliminary result of our study, and I will be sharing with you some highlights which support this cross-country regression results on how effective paid sick leave seems to be. So just very briefly, this slide shows you, this is the scenario 1 is what we already know. This is what would have happened if nothing was done. Scenario 2 is what would happen if after all the lockdowns in the Philippines, it was just released and then nothing else done. Then, you know, there's very little infection that is averted. All we did is just to move the date and the surge of infections. On the scenario 3, we put here what would happen if there's just ramped up testing. In this case, we're doing more than 50,000 tests a day, and it shows you that infections will decline, but testing alone is not enough. On the fourth scenario, we have just paid sick leave. What if paid sick leave is given to 50% of those with COVID and COVID-like symptoms? Again, it is it will help avert new infections, but it's not enough. So next slide, please. Here, scenario 5 is when the trajectory of infection suddenly changed. If you could see here the axis, it's very different from the first one. No, in the first 4 scenarios, we're talking about hundreds of thousands. Here, we're just talking about 10,000s. So scenario 5 is what we term new sustainable social distancing, which is in the Philippines, this is the minimum health standards. So this alone has the highest, is the source of highest decline in the number of infections. So this means that policies such as masks, such as banning gathering in public places, ensuring that there are social distancing protocols when we go to restaurants, malls, etc., as it is now in the minimum health standard, that will help avert a lot of infections. So in the context of sustainable social distancing, the closing of all schools, in fact, just increases the number of infections from 95% to 97, and you can see in the layering here that because of the different trajectories in how infection is spread among children and relatively older kids, it is different when you open the school just for younger kids and then older kids. Next slide, please. Now, when we layer this with ramping up testing and tracing and isolation into 50% of cases in conjunction with the sustainable social distancing, the infections really decrease. This is even when schools are open. Yeah. So, and then when we add paid sick leave policy here, basically, I would like to point out to the last scenario, the scenario 13, which is when we layer paid sick leave with ramped up testing, the results in terms of new infections, even if schools are open, is relatively the same. So the key takeaway is that even if you have opening up of schools, but with a combination of testing, tracing and isolation, and paid sick leave, you'll have basically the same number of infections. So I think what makes paid sick leave work, because we've been wondering about these results already. We already have the cross-country regression, and then we have this country-level modeling that is telling us this. And when we search the literature, this works in developed and developing countries alike. So among developed countries, the countries that have introduced this are New Zealand, almost all European countries, US to some extent, and in developing countries, Vietnam has had some isolation incentives to keep those with COVID cases isolated. They were giving them allowances. So basically, you can look at this as an isolation incentive, as an incentive for people who's showing symptoms of COVID to just stay at home. And this is very relevant for lower middle income countries because, as you know, many are employed in informal sector with no work and no pay policy. So when they are just feeling very mild symptoms of maybe it's COVID already, they will still go to work. And unfortunately, that is where the spread will happen. So if we could contemplate on giving them incentive to self-isolate there, as this modeling shows and as the cross-country regression shows, this might be an effective way of curbing out new infections. Another key point that I would like to zero in is the importance of data in opening up of economies. Models like this, or no matter how good the modelers are and the models, if the data is delayed or if there is no data, then there is nothing much that the models could do. So I think this COVID-19 crisis is telling us on how important it is to have real-time data. And not only real-time data, it's even more important to have access to granular data. There are many efforts already over the years in introducing open access surveillance system. Among those are the DHIS2, Open ELIS, Open LMIS, that lower middle income countries could introduce in their systems. I think I just would like to highlight the importance of standards. Since data is coming from different areas of the government, not just the Ministry of Health. There are data that is coming from the Interior Ministry, from Ministry of Transport, etc. It's very important that the data has a common standard so that they could be compiled. And when they are compiled, the analysis that could be gleaned from it is much richer. For example, a data that is there but rarely used in LMIC is the data from mobile operators, the call detail record. Right now, in our analysis, we have used Google Mobility, but that one is limited because it requires that the person has data plans. So most likely we are missing out on the rest of the population, right? But everybody has mobile phone, and therefore call detail record is a promising source of information regarding mobility. My last point is regarding the importance of regional cooperation. As we know from this COVID-19 crisis, regional health security is very important, and health security is a public good. But to make it happen, to make regional health security happen, we know that the virus crosses across borders and across nations. So it's very important that countries come together to have a more comprehensive way of addressing the issue. So in various lower middle income countries in ADB, we've had various groups of countries. We have the ASEAN, we have CAREC, we have GMS, who've had started looking at the regional health security as a block. And this will be very important as we move on as we plan moving forward into addressing the pandemic. So regional health security and regional health platforms will be very much important as countries start, for example, to procure vaccines. So for smaller countries, they could band together as a region so that they will have a bigger buying power in terms of vaccines. And they could also share data so that they will get alerted when new hotspots are crossing borders. Thank you.
Rose, thank you very much for those points, especially the one on paid sick leave as a tool for isolation based on symptoms. So we've actually got a lot of questions already, and there are a whole number that have a large number that have appeared over here. Let me start with one of the questions that has come up. It's not an issue that has been discussed so much, but I know that each of our panelists actually has been thinking about this issue, and this is views on school closures. And basically the question over here is, how does one weigh the benefits in terms of stemming transmission against the cost of lost education? So let me start with Keisha. Keisha, any thoughts on this issue about how to look at this whole issue of school closures?
So I feel that school closures may be important in the initial stage when you want to try and stem out any large-scale ongoing community transmission. However, schools should not be closed for too long, as research has shown that there could be other indirect impact of school closure, and that could be even more detrimental than, just COVID itself. So, so I think right now WHO together with UNESCO, they are all trying to understand what are the impacts of closing down educational institutions during this whole pandemic. And we look at other things such as gender-based violence going on at home, domestic violence when children are kept at home rather than being in school, the lack of vaccination because they're usually implemented at schools. So I think that we should not forget that there are other, implications of having school closed for too long. Yeah.
Thank you, Keisha. I'd like to actually give Rose a chance to answer this question, because this is, again, work that's being done. This is something that she's been working on together with her colleagues, David Reitzer and others. Rose, any thoughts on this one?
Yeah, thank you. Thank you, Rana. And thank you for those who asked that question. That question, I'm sure, is on everyone's mind. I also am a mom. I have a 5-year-old. And this is a question that I've been contemplating with. It's very easy to say just to let my daughter play for 1 year, but we have to consider the cost, right? So what cost am I talking about? So research shows that if a child, especially the younger child, if they are left on their own and they are not learning, they might not be able to catch up. So that's a very big cost to the human capital of my daughter, and if you multiply to the country, that's a lot, right? I think one thing that parents should remember is that even us as grown-ups, if we don't do something for a long period of time, we forget it. And the same is true with kids, except with kids, especially the younger ones, they have to achieve the numeracy skills, for example, until the age of 10. And if that window is gone, that's forever gone, and they will not be able to catch up. So I think I'm raising this question because it is important that we balance the cost and benefit. It is true that there is still community transmission of COVID right now, but we also have to think about the costs that it will entail. So I think to answer your question, I really like what Soonman was saying on the risk-based approach. There has to be a risk-based approach into looking at this problem. If an area has no COVID, then it may make sense to have some form of school opening in that area, for example. And in areas where there's still COVID, then we could do online learning, distance learning to supplement, but always with an intention that sometime in the future, when risks will be better managed, and it will be, we've heard various panelists talk about it, that there are certain ways wherein we could cut the risks for schools, and it should be opened as soon as possible for human capital considerations.
Thank you, Rose. We have a question, a very specific one, in fact, for Soonman, and it's basically on the kind of masks that are effective in protecting oneself from this virus, and what kind of, whether a particular type of mask is being mandated to be worn in Korea. Is it a surgical mask? Is it a cloth mask? So Soonman, very specific question for you here.
I don't remember the type of a mask, but until recently, until May, when it is not too hot, government recommended a mask which is for kind of high level, more sophisticated one. But nowadays, government recommends that more simpler type, like even something like a dental mask type, is enough. So I think it changed. It started with a very high level of, I forgot the medical terminology, but now it's changing to lose the standard, such that people are encouraged to use a simpler one, because this is getting hot and some people cannot have difficulty in breathing when they use a kind of higher standard one. Over.
Thank you, Soonman. In fact, one more question which comes up really in your line of your specialty area, Soonman, and that is, it's a question on the DMCs. the developing member countries in Asia, whether they still have health policies that don't really provide universal health coverage. And do you think having had a universal health coverage system would have actually made it easier to deal with a infectious disease such as COVID? So back to you again.
I agree that UHC is important, but in terms of priority as a response to infectious disease pandemic, I think preparedness, which makes early and quick response possible, that is more important than the UHC issues. I mean, especially in the short term. Of course, when there are huge number of people infected or potentially infected, UHC is very important because it provides a free access to testing or free access to treatment issues. But as I mentioned earlier, one of the most important success factors for COVID-19 is the early response. And probably what is the main factors for early response? I think I can say it's a responsiveness. I mean, sorry, it's a preparedness. So in the case of Korea, we are lucky that we had a very serious, painful experience of Middle East respiratory syndrome about 5 years ago. Before that, I mean, Korean system is also very terrible. But after that, the MERS experience is very important momentum for Korea to increase the preparedness. So of course we had the UHC, and UHC is the key. But even a country with a very good universal health coverage, like European countries, almost all advanced economies in Europe, they have a UHC. But when they fail to respond early, quickly, then they suffer. So I think for this COVID-19, early responses with preparedness, that is more important. Over.
Thank you, Soonman. Here's a question for Keisha, and others, of course, are welcome to also join in. It's the point being made here is that while testing is clearly a really critical factor in controlling this disease, testing is very expensive, especially for low-income countries. And while Philippines has done a good job in ramping up testing, other countries might not be. Keisha, are there alternatives to testing? Are there mechanisms of community monitoring? This is coming up directly in this question. So over to you.
Yeah. So, I mean, we know that testing is resource intensive, and for resource constrained countries, widespread and periodic testing may not be a viable option. And all the panelists has mentioned earlier, mask wearing, social distancing, keeping good personal hygiene are cheaper alternatives to, and cost-effective alternatives to testing. So it is really important that we, during this whole pandemic, we also do not forget the vulnerable populations. And I suggest that if you don't have much resources, you should always try to keep the testing in those vulnerable populations, test them more often to make sure that you don't have outbreaks coming up in those populations. So for instance, like care homes. So we've seen that in Singapore, we've seen that in Hong Kong and in the UK, how care homes have led to, infections in very vulnerable populations that eventually led to severe outcomes for many. So we want to make sure that we reserve the expensive solutions for very vulnerable populations. And in fact, the other interventions such as mask wearing, social distancing, and having a good personal hygiene is actually possible for countries at all income levels to implement them. There's also something like shielding of older members of the population to make sure that they don't come into contact with people who are potentially infected. So we're also recommending that countries which have who are resource constrained could consider encouraging or implementing shielding of the elderly population so that they will stay at home more often, more regularly, and not go out as often as possible. So I think that's other measures that could come in place.
Thank you, Keisha. Keisha, I'm going to ask you one more question because something has come up linking the presentation that Li-Ming had made, where it was shown that when you have strict lockdowns, you tend to see in the data that the lower income countries, developing economies in particular, you see people still relatively mobile. So in other words, the idea is that maybe in developing countries, it's actually very difficult for people to isolate at home. That's certainly what one of the charts that Li Ming showed is showing. Now, does that suggest to us that these strict lockdowns are bound to run into trouble in slum areas, in informal settlements, places where there's very high population density and large household sizes?
Yeah, that could very well be the case. So infected individuals isolate, they are asked to isolate during lockdowns, and this restricts their interaction with to members of their households as well. However, we've seen that, this would work in a setting where the household sizes are much smaller. And after several weeks of lockdown, and you see that after several generations of cases, we would tend to observe fewer cases being infected because of the saturation of contact. So everyone in their households are already infected and hopefully immune. However, in highly dense settings, so as you mentioned earlier, especially in slums and informal settlements, the lockdown could actually do the exact opposite of what you want it to do. So as the infected individuals are now able to come into contact with many more individuals who are susceptible because of the larger household sizes or larger settings in the community where they still come in to interact with one another. So I think in such settings, perhaps lockdowns may not be the best way moving forward. Okay.
Got it, thank you. Several questions here on paid sick leave. So I'm gonna actually direct this to Rose. And Rose, essentially the questions more or less, they relate to this issue of whether in a developing country context, in a context where you have a lot of the informal sector, whether a paid sick leave policy can really be implemented. How do you reach out to informal sector workers? So over to you, Rose.
The paid sick leave policy, for it to be useful, it has to be introduced to everyone who's working, especially the informal sector workers, because they are the ones who needs this incentive to self-isolate, right? Now, how do you implement that? I've been thinking through about that in the Philippines. So let me give Philippines as an example. Usually in the Philippines, there is already a social security system, and in most LMICs, there already is social security system that could be used as the conduit to have this sickness benefit. Yeah. And then how do we identify them? Usually, I mean, again, in the case of the Philippines, there are ways in which in the villages, we have to link it with the contact tracers, no? So the health system has this barangay emergency health response team. That could be the way for the informal sector employees to be verified that they are indeed sick. And then the money has to go through SSS. We are aware that, you know, there are many problems in transferring or the financial inclusion of the informal sector worker. But then, since we are going to contend with COVID for quite a while from now, you know, and maybe not too long, but still, it's not going to end very soon. Now it might be a good time, you know, hit two birds in one stone to also register these informal workers into the system so that they also become they also become included financially, and then you could give transfers to them digitally. Over.
Thank you, Rose. We are actually coming close to the end point for this, but there still are several questions, and we do have time for a few questions. This one is for Li Ming. So Li Ming, this is regarding the regressions you've run on taking the reproduction rate, regressing this on various control measures. And the question is specifically whether there's an endogeneity problem here, in that, isn't it going to be the case that countries with high reproduction rates of COVID-19, aren't those going to be the countries which are going to actually implement stringent lockdowns? Any thoughts on that?
So yeah, thank you, Rana. That's a good question. And in the specifications, we tested the different delays of policy implementations. And the result is actually quite robust against the like 3-day delays, 1-day delays, and 7-day delays. So in that sense, because the future RTs already are also taking account of the delays in reporting, so there has some distance between the policy implementations and the result RTs. So in that sense, we tackle the endogeneity problem from that angle. Thank you.
Thank you, Li-Ming. Soonman, a question has come, which I think it pertains to the Korean experience. This member of our audience has raised the issue that in countries like Korea, which have done a very reasonable and very good job in controlling this COVID transmission, it's okay for them to start thinking about restarting. But in lower income economies where the COVID spread is still ongoing, do they really have the luxury to think about the economy, or should they really be focused much more on the epidemiology side? That is, control the transmission of COVID-19 and then think about restarting later. So your thoughts on that, please.
I think it's a very difficult question, but I think there's a typical kind of a trade-off between saving lives and saving livelihood. And I think high-income countries and low-income countries are facing different types of trade-off, such that, I mean, I fully understand that the infection or how many confirmed cases, they are very important indicators. But as I mentioned very early at the beginning, I think we should have a very good balance, because we all know now we have more and more knowledge about the nature of this COVID-19, such that the fatality is very low. And there's another new evidence is that, okay, there's new variations, and these new variations is a higher RT, are not more infectious. However, it becoming less and less fatal. Then we should be, that's what I'm saying. So we should not pay too much attention. I mean, our decision making should not be based solely on the how many cases, how many infections, but we should have a bigger picture. How about the excess mortality? Because we have many other patients, cancer patients, many other patients in health sector. And also we should pay attention to the economy, because in low-income countries, people can die from COVID-19, but people can also die from malnutrition or die from poverty. So although I'm a health economist, but I think currently people are paying too much attention to the how many cases, how many infections. But is it really, is that the way we should go forward? I don't know. My answer, I'm becoming a bit skeptical about our too much attention, current attention level to the infections, how many infections? I mean, like a league table around the world. So I think it's time to have a more bigger picture. And as you mentioned, the school. Of course, when you open the school, we have more infections, but we should take into account the other socioeconomic costs. Even in Korea, I'm a strong opponent to the closing of schools, because when we close the school, there's increasing gap of the education performance of the students from different socioeconomic status. So this type of social cost is long-term, hidden. So people are paying more attention to the short-term COVID directly related cost. And we tend not to consider a long-term or hidden socioeconomic cost overall.
Thank you, Soonman. Very clear. It's a complicated issue, but I think you've made a very good point. I'm now going to actually ask each of our panelists to make a closing remark. Let me start with Keisha. Keisha, any takeaways from this discussion?
So I think that basically, if you want to control COVID-19, you need to think of innovative ways in which you can reduce the interactions between infectious and susceptible individuals. And this can come from a variety of control measures, from the extreme ones like a lockdown and border closure, but you can also think of other measures that are also effective, but perhaps less disruptive. So I think we need to bear in mind that control measures come at different degrees of effectiveness and disruptions, and we need to always think about, what combination is sustainable, and bear in mind the other socioeconomic cost that comes with the interventions that we implement, as what Professor Soonman mentioned earlier. So it's all about saving lives and livelihoods.
Rose?
So let me build up from Keisha's point on innovation. I think during this COVID-19 crisis, we've seen a lot of innovations, right? From the public-private partnership that Vince has shown us, to researchers coming together, telemedicine, task shifting, all these things. We should not forget all the lessons we've learned in this innovation in helping strengthen the health system. I think the focus should always be, in response to COVID, it should always be the strengthening of health systems so that crises like this will not occur again in the future. Thank you.
Thank you, Rose. Soonman, would you like to add something to that?
Well, I just want to repeat that we should have a broader perspective. This COVID-19 is not just a medical health problem, but we should view this from a socioeconomic broader perspective. And over.
Thank you, Soonman. And Li-Ming, you started this off with a very nice presentation. Any closing thoughts?
So I just want to reiterate that I fully agree with Dr. Soonman, is that the trade-off is very important in considering the long-term battle against the COVID-19. Mainly focusing on the short-term effects might not be capturing the full story. Thinking about the different costs is very important. Thank you.
Thank you, Li-Ming. And, I'm going to bring this webinar to a close, but I do want to just make one point. I've been struck throughout this crisis at this issue of data. And many of us over here are number crunchers, etc. And the role of data really has been fascinating. I don't think there's really been a situation we've seen anywhere in the world before where every single country is facing a challenge, a common challenge, where really the big issue, the decision-making really needs to be informed by data. And I think I very much agree with what's been already said, that let's hope that one of the things that we take away from this crisis is how to use data to inform public policy. And let's strengthen the capacities of the different agencies. You've got the private sector, you've got different public sector agencies, and let's really bring forward that point at which all these agencies are really, they become repositories for data, collecting data, analyzing data, and disseminating it. So with that, let me thank our presenters, our panelists, and all our participants. The audience has been really lovely. Lots of great questions over here. And looking ahead, I'd like to just invite everybody to our next Asian Impact webinar. It's going to be on Asia's journey to prosperity, the past, the present, and yes, we're going to get there post-COVID-19. This is going to be on the 12th of August at 3 p.m. Manila time, and we hope to see you all again. Thank you very much. Goodbye.